now the topic for Professor Sengupta is evidence-based optimization of EMPA and LINA fixed dose combination in patients of type 2 diabetes mellitus, and who can do more justice to this than Professor Nilanjan Sengupta. Over to Dr. Sengupta, who is Professor and Head Department of Endocrinology, Honorary General Secretary, Endocrine Society of Bengal, and Associate Editor to Indian Journal of Endocrinology and Metabolism. He is a Governing Council member to the RSSDI West Bengal Chapter, Secretary, Board of Studies in Endocrinology, West Bengal University of Health Sciences, Coordinator, DDCT course, State Medical Faculty of Bengal, and more than 80 publications in national and international journals. Over to you, Nilanjana, for the needful.
Thanks for your kind introduction, Shomobrato, and it's always a pleasure to be in the ENDAP Summit. Please allow me to share my screen. Hope it is visible.
Yes, sir.
So after the brilliant exposition by Dr. Rana Bhattacharjee, I will be definitely talking about EMPA-LINA combination, fixed dose combination, and I don't want to actually compress sulfonylureas in the hydraulic press of EMPA and LINA working from either side. I do acknowledge that sulfonylureas are there to stay in the market for the benefit of our patients. Having said that, let's look at the utility of this EMPA-LINA combination. As has been pointed out by Rana, uncontrolled glycated hemoglobin is a major concern globally. No matter what agents we use, how good insulins we have, how novel oral anti-diabetic agents we employ, there would be some patients who would be difficult to treat, who would struggle to achieve the glycated hemoglobin. And if you look on a broader perspective, from the individualistic to the global perspective, about 30% of patients globally of diabetes have a glycated hemoglobin beyond 9%, which is absolutely unacceptable. And only about 13% patients in this part of the world can achieve the desired glycated hemoglobin of 7. Now, this is the standard step care approach in the management of type 2 diabetes, starting with therapeutic lifestyle change alone, then adding metformin, probably adding a sulfonylurea, then adding a thiazolidinedione, and now probably a DPP-4 inhibitor, and then go on to insulin. Now, while acknowledging the utility of this step care approach, today we have become more aggressive, and we tend to start with combination therapy right from the very beginning in the life of type 2 diabetes. Why do we do this? We do because of two reasons. One, because of the understanding of legacy effect of glycemic memory. That is, if you can control hyperglycemia from the very beginning and can maintain it, then the patient reaps ultimate benefits in the long run. Second, we have now excellent agents in DPP-4 inhibitors, incretin analogs, SGLT2 inhibitors, not to forget about metformin, and even the now discarded thiazolidinediones, which can control hyperglycemia without causing hypoglycemia. So, in one word, availability of safer anti-diabetic agents have emboldened us to go for combination therapy in a much more aggressive way, thereby achieving and maintaining glycemic targets of 6.5 or 7 much easily. So we all know what are the factors for disease progression so far as type 2 diabetes is concerned, not only the glycated hemoglobin, but a BMI, which is unfavorable, a lipid profile that is atherogenic and unfavorable, and also the duration of diabetes. And of course, HbA1c at diagnosis and thereafter would be one of the main determinants of disease progression. Now, let's have an illustrative case. This 50-year-old gentleman has been suffering from diabetes, hypertension, and dyslipidemias in the last 2 years. BMI is on the higher side, is on metformin, but he is uncontrolled on metformin. Now, what to do in this case? So this is a very real life scenario with metformin monotherapy. The patient is having a glycated hemoglobin of 8.6. Both the fasting and PP are high, and the PP is quite considerably high at hovering around 280 milligram per deciliter. Renal function is not that bad. So what to do? So we all agree that we have to bring down the glycated hemoglobin in this patient. I would love to bring it under 6.5 from 8.6. That is almost 2 percentage point glycated hemoglobin down. And you can well understand a single agent alone probably is not going to do that. The common understanding is we need to give 2 agents on top of metformin to achieve our glycemic target of 6.5, at least 7. So the moot question is that, should we give a single agent, say a DPP-4 inhibitor, wait for 2 to 3 months, and then add an SGLT2 inhibitor, because these are the ones which we would be using rather than sulfonylurea. In my practice, as Rana has said, I keep sulfonylurea maybe as the 3rd or the 4th agent to add on in the treatment paradigm, unless there are other compelling circumstances. So the moot question is that, at this point of time, in a 50-year-old male who is having uncontrolled glycemia, A1C 8.6, who is obese with an additional risk factor of hypertension, do we give sequentially a DPP-4 inhibitor like linagliptin or sitagliptin and then add an SGLT2 inhibitor, or do the other way around, start with an SGLT2 inhibitor and add a DPP-4 inhibitor, or straight away give the 2 at one go? So there are certain August body recommendations of initiation with a combination therapy. Actually, the AACE ACE 2020 guidelines, or even before that, actually ask us to go for dual or triple therapy at initiation. If the glycated hemoglobin exceeds 7.5%, you go for dual, and if it's hovering towards 8.5 and 9, better to start with a triple drug, and if above 9, definitely a triple drug or with insulin. So there are recommendations. Now we come to the DPP-4 sulfonylurea, DPP-4 SGLT2 combination, because this is my brief this evening. You have already heard about sulfonylureas. Now, if you add a DPP-4 SGLT2 inhibitor like an EMPA-LINA combination, apart from glycemic control, you tend to get certain other pleiotropic benefits. Like this combination may be weight neutral or even effect weight loss, then it can also afford cardiorenal benefits. So if you go for the holistic metabolic management, not coming out from the glucocentric attitudes, then I think this combination suits well. And this, you know, is the ominous octet. And if you use this combination, it will actually target many of the defects that we encountered in diabetes, that is type 2 diabetes, that is defects in the enteroinsular axis, defect in the beta cell, defect of hyperglucagonemia, and so on. and so forth. Even to some extent, neurotransmitter dysfunction, and of course, metformin is already there, which can take care of the insulin resistance. So, as I said, this patient, of the three options, sequential use of DPP-4 inhibitor, SGLT2 inhibitor in that order, or the reverse order, or a combination of a DPP-4 inhibitor and SGLT2 inhibitor, a little bit aggressive therapy. At this point of time, I would rather go for an aggressive therapy. Now, whether you use a fixed dose combination of empagliflozin and linagliptin, or dapagliflozin and saxagliptin, that is up to you. You can use a fixed dose combination and you can use them separately also. But then if you have a fixed dose combination, you can decrease the pill burden and many a time also the cost of therapy. So I think that is a rational combination. And coming to the science behind it, apart from affording aggressive glycemic control, but without causing hypoglycemia or other major side effects, there is also a complementary efficacy. Simply because if you are using an SGLT2 inhibitor, there is tendency to loss of energy by way of glycosuria. And when there is loss of energy, the body will try to, as a compensatory mechanism, go for increased hepatic glucose output to counteract that energy loss. And that can be taken care of by an incretin-based therapy like a DPP-4 inhibitor such as linagliptin, so that this compensatory tendency towards increased hepatic gluconeogenesis can be taken care, that is seen with SGLT2 inhibition, can be counteracted if you are using a DPP-4 inhibitor in the same time. And we know with SGLT2 inhibition, there may be slight increased incidences of genital mycotic infections because of glycosuria. But there have been studies by Boehringer Ingelheim which tries to suggest that if DPP-4 inhibitor and SGLT2 inhibitor are co-prescribed, the chances of genital mycotic infections may be less, because probably it has been hypothesized that DPP-4 inhibitors also tend to inhibit the DPP-4 enzyme in the fungi. So apart from a more robust glycated hemoglobin reduction, we can have some benefits so far as side effects are concerned. So body weight reduction you can expect in these patients, because a DPP-4 inhibitor is weight neutral, whereas with an SGLT2 inhibitor, you can get about 3 to 4 kilos weight loss. So effectively, this EMPA-LINA combination can cause some weight loss, and this patient was having a glycated, having a BMI hovering around 29, 28 and a half, 29. So if the BMI can be brought down to under 27, like 25 or 26, that would be excellent. There may be an option for BP reduction because of the diuretic and natriuretic properties of the SGLT2 inhibitor and overall cardio protection. So as we all know, hypoglycemia with these agents is minimal. Neither the DPP-4 inhibitors nor the SGLT2 inhibitors cause hypoglycemia on their own, and that is advantage. And that is specifically the reason why we can afford to be aggressive at this point of time, which we probably wouldn't have been able to do with a sulfonylurea-based combination. The specter of hypoglycemia always looms large. So in this reference case, we can expect early and robust glycated hemoglobin reduction, a good weight and BP control, and with minimal hazards. That is the advantage. So that is it. Again, I told you, we have to look beyond glycemic control these days. I won't bore you with the details of the cardiovascular outcome trials that we have seen with empagliflozin, the very famous EMPA-REG outcome, which actually decreased cardiovascular death. And we have other studies like Carmelina with linagliptin, which has also attested its cardiovascular safety. And suffice it to say, combining the two will give the patient benefits of the two. What are the benefits of linagliptin apart from glycemic control? Renal safety, cardiovascular safety, ease of use, and so far as empagliflozin is concerned, the renoprotective properties, the cardio CV protective properties, decrease in body weight and intra-abdominal adiposity, which can indirectly improve insulin sensitivity. That is also a very important thing. This patient is overweight, having diabetes for a long time. Maybe this patient was also suffering from some degrees of non-alcoholic fatty liver disease that also can be taken care of by the SGLT2 inhibitor. So this is really a good combination. So as you all know, I think this is like bringing coal to Newcastle. You have been using fixed dose combination is available in 2 different once daily dosages. I need not go into the details of it, and they can be given any time of the day, irrespective of the about the last meal, and they and risk of heart failure. Again, you know, SGLT2 inhibitors are now being recommended for the management of heart failure, even without diabetes. So that is an important thing. So these drugs have good evidences behind them. Unlike you can say, okay, this is a slightly more costly combination. Why can't we think of a remogliflozin vildagliptin combination? Because that is also a combination of an SGLT2 inhibitor with a DPP4 inhibitor. But mind it, vildagliptin does not have any dedicated cardiovascular outcome trial, and there have been some concerns with diastolic dysfunction or even increase in the end-diastolic volume in the VV trial, and remogliflozin doesn't also have any cardiovascular outcome data worth its name. So if you have to use an SGLT2 DPP4 inhibitor combination for both glycemic and extra-glycemic benefits, you should choose 2 molecules which have data and evidence behind them. Just not just look at the cost of therapy, because as I said, this Vilda remogliflozin combination doesn't have evidence. So I think we can skip this slide. Again, if I have to choose DPP4 inhibitor, my choice would be sitagliptin or linagliptin, rather than saxagliptin or vildagliptin if we consider the heart, or even allogliptin, because there are certain disturbing signals so far as heart is concerned. And if I have to select an SGLT2 inhibitor for both cardiovascular, cardiorenal, and glycemic benefits, it has to be empagliflozin, dapagliflozin, or even canagliflozin, but not definitely remogliflozin, which do not have data on the pleiotropic benefits. So I think not only for the treatment of hyperglycemia of diabetes, but for holistic metabolic control, this is an important fixed dose combination, important, rational, cost-effective, and medically effective combination, which can be in a patient like this. And this is the cost, I think, if the patient asks you, why are you giving a costly pill like this? Then you can explain to the patient that if you treat diabetes well for years from the beginning of your diabetic life, ultimately you have to spend less on hospitalization, spend less on doctor visits, spend less on laser photocoagulation, intravitreal pharmacotherapy, repeated dialysis sessions, transplantations, CABG, so on and so forth. So I think in this patient, in this illustrative case, I have shown the importance of not only early initiation of therapy, but early intensification and early intensification with a combination of empagliflozin and linagliptin, that is a DPP4 SGLT2 inhibitor combination. So with this, I thank you for your patient hearing, and I again thank the organizers for inviting me as every year for their MDAP Summit on Charles Best Memorial Day, and making me a proud part of it. I was listening to the quiz, which also I thank Shomo Broto for taking this great step of honoring this quiz in the name of late Santosh Rastogi. The quiz was a very interesting one. I learned many things from the quiz itself. And this is actually a picture of Charles Best with his compatriot, Clark Nobel, who actually lost the toss of the coin to assist Banting. That's why he has not been that famous, but he also went on to become a good scientist, and he was been credited to discovering wind blasting. So I think that we tend to forget. So I took this opportunity to tell you this little anecdote, and I thank you. And if there are any questions, I'll be glad to take them.
Thank you, Nilanjanda, ebullient as always, and I'll come back to you after the promotional video. Thank you, Nilanjanda. Thank you for that wonderful talk. There are two egging questions out here. One delegate has asked, considering this to be a scientific forum, if we keep economics out of our baggage, how would you consider the peptide in a pill in your case? Would you consider? Would you not consider, and why?
Yeah. Definitely, I would consider peptide in a pill in lieu of the DPP4 inhibitor if we want a greater glycemic control. But how can I ignore the economics? Because pharmacoeconomics is a good thing. In this patient, if the job is well done with a DPP4 inhibitor and an SGLT2 inhibitor combination, maybe separately or in a fixed dose, that's your choice. I may not consider a peptide in a pill. But yes, if I put this patient on this regimen, after 6 months, I find the glycated hemoglobin is 7.2 or 7.3, then I can think of persisting with the SGLT2 inhibitor and replacing the linagliptin with semaglutide or ribelsus as it is available if the patient's pocket permits, and if there are no other contraindications. There are actually not much contraindications. If you can use linagliptin, for that matter, you can also would be able to use semaglutide. But I think I would give, in this patient, in this illustrative case, I would first try to give linagliptin a choice, a chance. If linagliptin fails, then I think semaglutide is always there.
Now there's a second one coming up for you. Keeping economics in mind, and keeping in mind that we are possibly going to have a CETA and a DAPA combination in times to come, and both in generic form, what would be your choice? Would you choose that?
Yeah, conceptually, a CETA-DAPA combination, so far as pleiotropic benefits is concerned, upfront, prima facie, would be much better than a Remo-Wilder combination, so far as cardiovascular and renal disease is concerned. But then one argument you have to keep in mind, Professor Chaudhary is there. He actually asked me this question in another forum. But if you are talking of that, the data that has been generated are with the innovators, not probably with the bioequivalent molecules. Can you really extrapolate the data? So this question is difficult to answer because whatever data you have with innovator dapagliflozin and innovator sitagliptin, whether that can be extrapolated, but well, if the cost of therapy is not an issue, I would still go by the innovator brands. But if cost of therapy is an issue, I would rather give the benefit of doubt to a CETA-DAPA combination than a Wilder-Remo combination for the glycemic as well as extraglycemic pleiotropic benefits.
So at the end of it, the proof of the pudding will be in the eating, I suppose.
Right, but how can you really prove? Because for cardiovascular endpoints, you have to wait for 10, 20 years. For the glycemic thing, the proof comes early. That's also an issue.
Thank you, Nilanjana. That was a very, very enlightening case discussion. And we also have, we had two futuristic questions for you, and you have answered both of them in a very, very scientifically valid way. And I think it would give our delegates a lot of learning points in their practice. Thank you so very much for being with us every year, and we would love to have you the next year, but in person.
I think I would love to attend physically, the COVID situation permitting. Thank you.
Thank you so very much. And